Assalamu alaikum. This is Dr. Mariam Al-Abdallah, a professor in orthodontics at the University of Jordan and a senior orthodontic consultant at the Jordan University Hospital. Today's lecture is the third lecture regarding interceptive orthodontics. Now, just to remind you, chapter 3 from Littlewood and Mitchell, 5th edition, and Introduction to Orthodontics. Some articles and some guidelines could be included. So our third lecture. Today we're going to talk about spacing, crowding, anterior crossbite, posterior crossbite, and increased overjet. Right, spacing and crowding. It's important for you to know that during the deciduous dentition, it's normal to have spacing, generalized spacing, and it's also normal to have specific spaces that are located distal to the lower C's and mesial to the upper C's, and we call these primate spaces. Primate spaces, okay? So these are spaces in addition to the generalized spaces. And this is normal, okay? Because we need some space to accommodate the wider mesiodistal permanent teeth compared to the deciduous teeth. So during the early mixed dentition, in the upper arch in specific, okay? This is what we can see through this OBG. We can explain this in this OBG. So you can see here that we have the permanent upper incisors, the permanent lower incisors, and the permanent first molars erupting, okay? So this is early mixed dentition. At this stage in the upper arch, the canine that has the longest path of eruption is actually guided by the distal side or distal surface of the root of the upper laterals. So it's normal that it is pushing slightly and gently against the root, and this ends up with flaring of the upper labial segment. So in the early mixed dentition, it's normal to have spaced upper labial segment, okay? And this is what we call the ugly duckling stage, just within this terminology is used within the dental professional. We don't use it with the patients, of course, and their parents. It's not a nice terminology. Anyway, so if you have very concerned parents who comes to your clinic complaining about spaced upper labial segment in this at this stage, then you just need to reassure the parents that this is normal, okay? Of course, you do this after you go through the comprehensive history taking and clinical examination, if necessary, radiograph as necessary, okay? And then you need to confirm that this is a normal physiological development if this is what you see, okay? If there is any family history of impacted canine, dental anomalies, if the diastema between the incisors is more than 3 millimeters, then you need further investigation and you might need some management for such cases. So a diastema between the incisors up to 3 millimeters without any underlying pathology or problem or dental anomaly is considered a normal physiological developmental stage of the dentition. Just reassure and review the patient every 6 months. If it's more than that and the space for the erupting lateral is being affected, so we have potential impaction of the lateral incisors, and if the patient presented way before the eruption of the canine, so which means that movement of teeth will not affect the canine, that means we could do something for this patient because more than 3 millimeters of diastema is going to affect the aesthetic of the patient and might cause some psychological problems that affects patient's self-esteem and confidence. And so what's the management? After you exclude the presence of supernumerary through taking radiographs and excluding any pathology and confirming presence of the permanent teeth, then we can check the position of the incisors, their angulation in specific. If the incisors are upright or distally tipped, then we can choose simple removable appliance to produce a simple tipping movement. Our active component is a palatal finger spring on this incisor and a palatal finger spring on the other incisor, okay? You can see it here. So the active components, palatal finger spring, to move the incisor within the line of the arch mesially. The rest of the components are related to retention, so we can use Adams, C clasp on the D or another atom on the D. It depends on the case. If you use Adams on the 6s, it's 0.7 millimeter stainless steel wire. Adams on the Ds, it's 0.6 millimeter stainless steel wire. So on the 6s, it's 0.7, on the Ds, it's 0.6, and the palatal finger spring is made of 0.5 millimeter stainless steel wire. Okay, and you simply activate the palatal finger spring, and after about 3 to 6 visits, this is usually closed. And you just need to add a bonded retainer at the back palatally in order to maintain the results. If the incisors were mesially tipped and you have a diastema that is more than 3 millimeters, then it's important to go through bodily movement in order to correct such malocclusion, and you will need to use fixed appliance. Right? So this is the management of a patient who comes complaining of diastema. So this is an example of a patient. You know, if a patient comes to your clinic saying that he's being bullied at school, you cannot send him back saying, no, this is a normal physiological development. No, this is not normal. First of all, it's more than 3 millimeters. Second of all, the eruption of the lateral incisor is being compromised because there isn't enough space. So you have to go through the conventional thought of history taking, clinical examination, radiographs to exclude pathology. And then after that, this patient is presented with an upright upper left central, distally tipped upper right central, upper left central is upright, so we can use simple removable appliance with palatal finger springs in order to close the diastema. And this patient needs management. Right. In the early mixed dentition in the lower arch, on the other hand, it's normal to have mild crowding. Okay, so if you are presented with parents who are very concerned about lower incisors that are erupting, being rotated or a little bit lingually displaced, as long as this is mild crowding in the absence of pathology, etc., then this is a normal physiological development. Okay, just reassure and review the patient every 6 months. If the patient comes to your clinic looking like this, their child is looking like this, then again, for this case in specific, you just need to extract the A's and review the patient every 6 months in order to make sure that the function of the tongue will actually normally push the incisors more labially to a wider arch. Okay? Reassure, review the patient every 6 months, make sure that you extract the A's before anything else, and review the eruption of the laterals. Okay? Now, there has been a study, a randomized clinical trial, looking at patients who presented with crowding in the lower labial segment according to the little irregularity index of 6 millimeters or more. And they divided the group into randomly into 2 groups, these patients. A group that had no treatment and a group that had extraction of the C in order to provide space for the crowded lower labial segment. And they reviewed the patient. In the short run, they found that there was a relief of crowding of the lower labial segment. But after review, 2 years review, they found out that the crowding was actually only shifted to the buccal segment and the overall length of the arch was reduced, which means in the long run, this procedure is questionable. So it's not recommended. You don't need to extract the C's in the lower labial segment to relieve mild crowding, because as we said, this is considered normal physiological development. Okay, more than that, you just need to wait for the incisors to erupt, and then you can manage the crowding using, for example, leeway space or other methods. Right, now we come to a planned extraction of deciduous teeth. Okay, we talked about early loss, which is unplanned. We talked about retained, and now we're talking about planned extraction of deciduous teeth during the mixed dentition. There's something called serial extraction, and this terminology is considered a historic terminology. Okay, and the idea was to try to shift the crowding from the labial segment all the way to the buccal segment, ending up with losing 1 premolar in each quadrant. This methodology was actually invented and introduced in order to reduce the patients who are referred to orthodontists, because number of orthodontists at that time in the 1940s was less than needed by the general population. So they tried to allow the general dentist to handle some orthodontic patients as much as possible and reduce the load on the orthodontist. So this is like a recipe for the general dentist to handle patients who are presented with moderate crowding and they needed serial extraction. Okay, this is not the case anymore nowadays. Now we have plenty of orthodontists. They are specialized and they can do the proper treatment for the patients. But still, um, for very, very carefully selected cases who are reviewed every 6 months minimum by the orthodontist, we still use the serial extraction. So it's important for you to know the concept. The concept is in a patient in the early mixed dentition where we have potential crowding of the laterals and the canines, then we can try to shift the crowding from the labial segment to the posterior segment as follows. First, we extract B's and C's, okay? The deciduous lateral incisor and the deciduous canine. And then we wait for 6 months for the eruption of the laterals. After the eruption of the laterals, we send the patient for the extraction of the D's, okay, which is the first primary molar. And after that, we wait for the eruption of the fourth, which is the permanent first premolar. After the eruption of the first permanent premolar, then we extract them and we review eruption of the canines, okay? We don't touch the E's. We don't go all the way back. So this is how we do it. We extract B, followed by C, followed by D, and at the end we extract the 4, okay, in a certain and specific sequence. And we wait between each step and the other, okay? Ideally, the classical cases are patients who presented with a class 1 malocclusion with moderate crowding. But all permanent teeth should be present. If you have congenitally missing, then this is contraindication. If you have severe crowding, this is contraindication. If you have mild crowding, this is contraindication. It has to be carried out by the orthodontist, okay? So an example of a patient class 1 malocclusion, as you can see here, this is the patient pointing edge to edge, but this is the proper maximum thickness patient, class 1 malocclusion in the mixed dentition. So the decision was made to go through serial extraction. Now, to be honest, this is a patient who presented a bit later than the ideal age, okay, because we need to extract the B and then the C, but we already have the lateral incisor erupting and crowded, okay. So anyway, this is done by the orthodontist, so and a decision made by the orthodontist and not the general dentist. This is my patient. So the first thing we do is to make sure that all permanent teeth are present, okay? So we have the canine, the 4 is already erupted, and the 5, and again the canine 4, 5, 3, 4, 5, 3, 4, 5, all permanent teeth are present. And now we can carry out the extraction as planned. So we extract the C. In the lower arch, there is no C, so we extract the 4, and we extract the 4, and we extract the C on the lower right quadrant, okay? Then we wait for the eruption of the 4s in the upper arch. So this is after the extraction, as you can see. C is gone, this is the 4, this is the 4, and the C was extracted. We don't touch the E's. The E's are not part of the plan. They can exfoliate by themselves, okay? This is not part of the plan. As you can see, the severely crowded canine in the lower arch has erupted. Now we can move to the next step in the upper arch, which is extraction of the 4s. So we extract for the 4s and we wait for the eruption of the canines. One of the canines erupted, the other didn't, so we had to take a radiograph to make sure that we are actually on track and everything is going as planned, yes. And because the patient started later than the optimal time, then we expect to have some residual spaces. So this is not perfect, but at least the patient went from this malocclusion to this malocclusion with now it's easier to go through fixed orthodontic treatment just to align and level and close the residual spaces. So the patient went from a difficult case to now a simple case that would benefit from a simple orthodontic treatment. Another example of a patient in the mixed dentition, as you can see, the canines are buccally erupting and they are crowded. So the first thing we need to make sure that the patient is cooperating. By the way, the key of success for serial extraction is a cooperative patient who comes to their appointment. If they don't come, then the treatment will fail, okay, will have consequences and problems. So we take a radiograph and the first thing we notice is a congenitally missing 5. So this is contraindication. We don't go through serial extraction. If extraction, then it has to be under the supervision of the orthodontist. Another example of a patient who presented with a class 1 malocclusion, and as you can see, this is a classical case for serial extraction. Yes, because we have the lateral incisors are crowded, there isn't enough space for them to erupt, and also crowded lower labial segment. We're still within the moderate crowding condition. So the first thing we do, we make sure that this patient is cooperative. We make sure that the patient is maintaining excellent oral hygiene, and then we make sure that all permanent teeth are present. Whoops, the lower fives are missing, right? The lower fives are missing, and we have the E's, no 5. So it is contraindication to go through serial extraction in the lower arch. This patient was treated under my supervision, so I did decide to go through serial extraction in the upper arch only, not in the lower arch. Okay, so we started by extracting the C's in order to provide space for the lateral incisors and wait for the eruption of these lateral incisors. After that, we extract the D, okay, to allow the force to erupt, and after the force eruption, we extract the force, and then we review eruption of the canines. Okay. In the lower arch, because we have congenitally missing 5s, we had to extract the E's, but we had to make sure that the patient actually is coming to their appointments and they are complying with the treatment. So this is the radiograph after extraction of the C's. So we extracted the C. What happens to the laterals? Immediate eruption. So they immediately erupted. Everything looks good, and now we sent the patient to extract the D, upper D right and upper D left, lower E on the right side and on the left side. Unfortunately, the patient went away. They disappeared for a couple of years, maybe 3 years, and they actually came back with this. So they managed to extract the D's and only the lower right E, but not the lower left E. So now we have a problem, right? So as we said, key for success for serial extraction is a patient who comes to their appointment. And now we have a problem. We have severe crowding in the upper arch, potential impaction of the upper canines, center line discrepancy in the lower arch, with most of the spaces closed for the E, but the other E is submerging, and we have plenty of space that needs to be closed. So now the case has shifted from being a serial extraction with just review of the case. Now we need to go through active orthodontic treatment. So we sent the patient for extraction of the 4s and the lower left E, as you can see here. And now we needed to go through active orthodontic treatment in order to open space for the canine and orthodontic surgical exposure and orthodontic treatment, active orthodontic treatment and traction. Okay, so although the concept is simple, but it needs a professional orthodontist to carry out the treatment. And there are lots of problems that could be included in such a technique if the patient showed, for example, poor oral hygiene or poor compliance, or we did the wrong decision, especially with congenital missing teeth. So it's important to go through the whole assessment. There are some indications for extraction of deciduous canines. Okay, the first one, if we have crowded upper arch where the erupting of the lateral incisor is forced palatally or is not erupting at all, like the case that we just saw. Okay, so if this is the case, then we can extract the C in order to allow eruption of the lateral and then assess the potential crowding that has happened. We did not solve the problem of crowding, but we gave the priority for the lateral incisors to erupt at this stage, and then we will handle crowding later on. If you had to extract the C on one side in order to provide space for the lateral, you have to extract the C on the other side so that you don't actually cause a line problem. Okay, we don't treat a problem and cause another one, because it has to be a comprehensive treatment for the patient. We could actually also extract the deciduous canine to provide space for orthodontic treatments. For example, this is a lateral incisor in the palate. I want to push it by simple tipping movement through the use of simple removal appliance. I need space. So the decision was to extract both C's and then use a simple removal appliance with a Z spring in order to correct the crossbite on this tooth. And then we need to handle the crowding of the upper arch later on. Another example is in patients with a crowded lower labial segment with one incisor being pushed labially. as you can see here, with a compromised gingival margin. Or in the lower arch, if we have a class 3 malocclusion. We need to be here very, very careful, because this is a list that has been provided to you by the chapter that I gave you as a reference. But we need to understand that there has been, as we already said about the lower incisor crowding, the randomized clinical trial that said if you extract the C to relieve crowding, this could be successful in the short term, but in the long term, there is a questionable benefit. The crowding that you have relieved was actually only shifted to the buccal segment, and you ended up with a shorter arch length, which means a bigger problem. So this is not recommended anymore. Okay, the relief crowding is simply not recommended anymore. And finally, to improve the position of a displaced permanent canine, we talked about this in our second lecture on interceptive. If you have a canine that is drifting from its normal path of eruption, then extraction of the C could help to normalize the position of the canine. But only in uncrowded cases you could go for extraction of C and review every 6 months. But if you have crowded cases, you need to provide space in addition to the extraction of the C and review the patient every 6 months. Okay, you need to provide space. Right, we come to another problem, which is an anterior crossbite in the mixed dentition. You have to diagnose such cases as early as possible, because such cases can cause attrition of the labial surface of the upper incisors, maybe traumatic occlusion with mobility or fracture. You can have gingival recession of the lower labial segment, as you can see here. So we have crossbite on the upper left central incisor, gingival recession. Of course, compromised aesthetic, and the patient will grow, and his occlusion will develop into a class 3 profile. Okay, so these are all reasons why we need to diagnose such cases early and go through active orthodontic treatment. More teeth that are involved in the anterior crossbite, the more severe the consequences and the more need for treatment. Okay. How can I manage such cases? Well, if I have a single tooth in crossbite, I can construct a simple removable appliance with a Z-spring in order to push that tooth across the bite. I need retentive components that are enough to retain the appliance in place with minimal of 3 points, and I need to modify the appliance using posterior bite plane. If I have 2 adjacent anterior teeth, then I can use Z-spring. Instead of being 0.5 millimeter for a single tooth, then I need to use Z-spring that is a little bit longer of 0.6 millimeter stainless steel wire. And again, I need retentive components and I need posterior bite plane. If I have 3 teeth that are involved in the crossbite or more, then it's better to use anterior expansion screw in order to correct such malocclusion. And again, I use enough retentive components and I use posterior bite plane. If I have, in addition to the crossbite, some rotation, malalignment of the incisors, then I can use the 2x4 system. 2x4 system is a fixed appliance system. So this is a patient with a crossbite on the upper right central incisor. As you can see, we use Z-spring 0.5 millimeter stainless steel wire, enough retentive components, posterior bite plane in order to just occlude the teeth. Another example, the upper left central is in crossbite. So again, I use simple Z-spring and enough components for retention, and posterior bite plane is a must in order to disocclude the teeth. The Z-spring is 0.5 millimeter stainless steel wire. So this is just to show you an unfortunate patient who presented with anterior crossbite that needed a little bit lengthy fixed appliance in order to correct the crossbite. You can see the gingival recession of these 2 incisors compared with the others that are in a normal bite. So these are consequences. Although we corrected the crossbite, but you can see that the labial surface of this incisor did actually suffer attrition, and it needed some composite to improve aesthetic. But the crossbite was corrected after all. Now, if you have anterior crossbite that involves 3 anterior teeth or more, you need to sit and think about 3 questions. Is there mandibular displacement or not? Can the patient bite edge to edge? Is there family history of class 3 skeletal pattern, class 3 malocclusion? Is there enough overbite to guarantee stability of my corrected anterior crossbite or not? Okay. These are very important questions because you can move from a case that is very simple that can be treated by the general dentist to a case that is difficult and needs to be treated by the orthodontist. Okay, so just let's look at this short video showing you the anterior crossbite with mandibular displacement. Okay, you can check this by asking the patient to bite edge to edge. So if they can bite edge to edge and then the mandible is displaced anteriorly, then we call this pseudo class 3. Okay. Because edge to edge is a premature contact. It's uncomfortable. So the patient is trying to find a more comfortable position to go through maximum intercuspation by displacing his mandible forward. Okay, so this is a pseudo class 3. So if the patient has pseudo class 3, which means that there is anterior mandibular displacement, and if there is no family history of class 3 malocclusion, and if the overbite is positive, average, or even increased, then all these criteria will tell you that the treatment could be successful using simple removable appliance by the general dentist. Okay, as we said, the design is simple, just an anterior expansion screw. We cut the acryl based on the segment that is being affected, and we apply the anterior expansion screw. We apply enough retentive components and posterior bite plane, and the patient can activate this screw actually twice a week until the crossbite is being corrected. As we said, we can use 2x4. It is called 2x4 because 2 are the 2 bands on the posterior permanent molars, 4 are the 4 incisors brackets. Okay, so it's 2x4, and it is indicated if we have alignment in addition to the crossbite. So we have rotated teeth. A fixed appliance is of course less dependent on patient compliance compared to the removable appliance. And we have more controlled tooth movement control compared to a simple tipping movement provided by the removable appliance. It is efficient if we have more than one incisor and crossbite and if alignment is required as well. So this is an example of a patient with a crossbite where we use 2x4 appliance to treat the malocclusion. On the other hand, if the patient is presented with a real class 3, no mandibular displacement, family history of a class 3 malocclusion, and not enough overbite to guarantee stability at the end of the treatment, then you need to refer the patient to the orthodontist as soon as possible, because such cases between 7 years old and 10 years old is the golden window to provide orthopedic treatment. Please go back to your lecture about growth modification, and there is some explanation about face mask treatment for such patients, where we need to enhance forward growth of the maxilla in order to have an orthopedic effect and a growth modification to correct such cases. Okay. Right, so we need to talk about posterior crossbite with mandibular displacement. This is another type of malocclusion that is presented in the mixed dentition that the general dentist can treat, and we can carry out an interceptive orthodontic treatment. Okay, so let's look at the video. As you can see here, a patient with proper occlusion. Okay, now as the patient open and close, if there's premature contact, the patient has to shift his mandible to the right or to the left to get maximum intercuspation. Okay, what do we mean by premature contact? It's edge to edge bite, exactly like this. So the patient is biting his teeth in the centric relation, the teeth are bited edge to edge, and this is not comfortable. This is a premature contact. If the patient continue to close, they will close in the maximum intercuspation. So you can see the patient had to shift his mandible to one side. It could be the left, it could be the right. Okay, and gradually this will be a habitual bite. So as you examine the patient will go directly to shift his mandible to the left. Okay, you cannot see this beautiful slow motion edge to edge and then moving his mandible to one side. A patient sits on the chair and you ask them to bite, they will bite directly to this position. So how can I diagnose a patient with a crossbite with mandibular displacement? Sign number 1 is to have facial asymmetry because the mandible is shifted to one side. So you can see that the chin is pointing more to the, going more to the left or to the right. Number 2, as you examine the occlusion, you will see that there is a crossbite on one side only, buccal crossbite on one side only. Number 3, you will see that there is central line shift. the lower center line is shifted where the mandible is actually shifted. Okay, so these are three signs important to tell you that there is something wrong. Most probably unilateral buccal crossbite with mandibular displacement. So again, the patient is biting edge to edge and then shifting his mandible to one side. What's the treatment? The treatment is to eliminate the premature contact. How? By expanding the upper arch. What do we use? Well, it depends. If the case is mild and the problem is dental only, and I need a simple tipping movement, then I can use removable appliance midline expansion screw. Okay, the patient can use this and open it twice a week. If the case is more like moderate and it's a combination between skeletal and dental, then I can use quad helix to expand the upper arch, which is a fixed appliance. If the case is more severe, very constricted maxilla, mainly skeletal, and we need lots of expansion, then I can use a rapid palatal expansion, which is a fixed appliance that is used for body movement and for skeletal modification of the maxilla. Okay, so what appliance do I use? It depends on the case. If I have simple unilateral buccal crossbite with mandibular displacement and it's mainly dentally, then the appliance that I choose is a removable appliance or a quad helix. According to the Cochrane reviews and evidence-based, quad helix is more efficient. Both of them, both removable appliance and quad helix, could end up with a successful treatment, but quad helix could be more efficient in providing the treatment, right? You need to understand that there is a weak association between the posterior crossbite and mandibular displacement in relation to the temporomandibular joint dysfunction, but that doesn't mean that I don't provide space. Okay, although there is no strong evidence, but the habitual mandibular displacement and the functional shift of the mandible should always require treatment, because otherwise I will have asymmetric muscular activity and the whole occlusion will develop into such a displaced position of the mandible. Okay. So as we said, management could be expansion of the maxilla, removable appliance, quad helix, rapid palatal expansion. Sometimes if the case is very, very mild and there is very clear premature contact on deciduous teeth, then we can go for grinding of the premature occlusal contacts on the primary dentition. Not the permanent teeth. You don't trim. You don't grind the permanent teeth, only if there is very clear premature contact on deciduous teeth, usually these are the C's, then you can go for selective grinding until you eliminate the premature contact and you correct this displacement. So this is a simple case. If you look at the case, if you have extraoral photos, you will see an obvious facial asymmetry where the chin is pointing to one side, usually for this case, for example, it's to the left. You can see intraorally unilateral crossbite on the left side, and you can see that the lower center line is shifted to the left side. So what do? I need to treat this case as soon as possible, as soon as I diagnose it, okay? I take upper impression, I go for a removable appliance, midline expansion screw, enough retentive components, and the patient should activate the appliance twice a week until the correction of the buccal crossbite. You need to add posterior bite plane in order to just disocclude the teeth. Posterior bite plane in order to disocclude the teeth. Right. What if no treatment was provided for such cases? Well, you will end up like this, a permanent dentition with a narrow maxilla, usually buccally displaced canines, as you can see, unilateral crossbite, mandibular displacement, centerline discrepancy. And now the patient will need a lengthy orthodontic treatment, conventional orthodontic treatment, quad helix, expansion, fixed appliance. We try to correct the crossbite and we end up with an acceptable occlusion. So if the patient had an early orthodontic treatment, at least this will not end up with a full correction of the malocclusion, but at least the patient will present with a less severe type of malocclusion with no functional shift of the mandible. Okay. Now we come to class 2 division 1 malocclusions with increased overture. Please go back again to our growth modification and functional appliance lecture because this was explained in detail. A patient with a class 2 division 1 malocclusion and skeletal class 2 due to retrognatic mandible, the ideal treatment is usually functional appliance. The optimal time to use functional appliance is late mixed dentition, early permanent dentition. But sometimes we need to go through interceptive orthodontic treatment during the mixed dentition. So a treatment that is provided before the optimal time. Why? Well, only in cases where we have risk of incisor trauma due to increased overdebt, or psychological well-being is being compromised due to bullying, self-confidence is being affected due to the increased overdebt. For these patients, these are the indications for an interceptive treatment. So we need to go through interceptive treatment, of course, using functional appliance in order to enhance forward growth of the mandible and to reduce the overdebt. Okay. So, as a general dentist, what do you need to refer and when? Okay. During the deciduous dentition, we hardly need to see the patient as orthodontist. Okay, unless the patient is presented with syndrome, severe skeletal problem, cleft lip and palate patient, so a severe problem, a syndromic case. Okay, otherwise, in the mixed dentition is the best window to provide most of the interceptive orthodontic treatment, and this is the job of the general dentist, pediatric dentist, and the orthodontist together. Okay. And as we already covered, patients with severe class 3 skeletal problem, they can benefit from orthopedic effect using face mask, as we said. Please refer to the orthodontist. Delayed eruption of the permanent incisors, go back to the Royal College of Surgeons of England's guidelines. Presence of supplementary incisor, decision to extract or not, and when to extract also already been explained. Impaction or failure of eruption of the first permanent molars is what we call ectopic molars. First permanent molars of poor prognosis. Again, we talked about the new guidelines in March 2023. Ectopic maxillary canines, we talked about this. Hypodontia, marked mandibular displacement on closure due to anterior crossbite or posterior crossbite with mandibular displacement has to be treated as soon as being diagnosed as early as possible. Patients with medical problems where monitoring of its occlusion would be beneficial, and pathology like cyst. Okay, so these cases were already explained in details during our previous lectures and this lecture as well. Just finally, growth modification for patients who are presented with a class 2 skeletal pattern due to retrognatic mandible. We said that the best time is during the early permanent dentition or late mixed dentition, unless you have patients with increased overdebt who have been psychologically being affected, severe teasing, or with upper incisors that are at risk of trauma, usually due to grossly incompetent lips. These patients will need a treatment that is provided before the optimal time, what we call interceptive orthodontic treatment. I'll just give you the final example here. This is a patient with typical criteria that we just talked about. Number one, incompetent lips, grossly incompetent lips with short upper lips. So the upper incisors are not being properly covered. So we have risk of trauma. These are incisors at risk of trauma, increased overdebt, class 2 skeletal pattern, retrognatic mandible. All these are telling you that this patient needs an interceptive treatment during the mixed dentition. Okay, not at the late mixed dentition or early permanent dentition, which is considered the optimal time. We need to do this earlier for this patient in specific. Okay, so this is covering all topics about interceptive orthodontics. Thank you for listening.